Dave Freeman is here. He is a professor of neurology and neurosurgery at the Mayo Clinic in Jacksonville, Florida. His latest research has focused on this very important topic of anticoagulation and intracerebral hemorrhage, which he is going to talk about today.
Thank you for the kind introduction, Dr. Manno. It's my pleasure to speak to you today on this important topic of anticoagulation and intracranial hemorrhage. Basically what this means is patients who have intracranial bleeding in the setting of blood thinners or anticoagulation. And I have no conflicts or of interest or disclosures to report with any industry or devices with relation to this talk. So we'll go over the learning objectives, which are outlined, as you can see. The first is we're going to go over the mechanism of warfarin and the novel oral anticoagulants, also known as NOACs for short. Second, we'll go over the epidemiology and the natural history of anticoagulation intracerebral hemorrhage, or ACICH. Third, we'll go over the approach to acute management of this disease. And fourth, we'll go over when and if patients should be restarted on anticoagulation after they have an anticoagulation-associated intracranial hemorrhage. And lastly, we'll touch on some future research going on in the field. So it behooves us to go over definitions as shown on this slide, namely antithrombotics, which are antiplatelet agents such as aspirin and clopidogrel, as well as anticoagulants such as warfarin, and namely the novel anticoagulants or NOACs. And the ones highlighted there, warfarin and the NOACs, are the focus of today's talk when patients have intracranial bleeding. So on our next slide, what we see is the prevalence of atrial fibrillation, and atrial fibrillation is the most common reason for prescriptions of anticoagulants such as warfarin and the newer NOAC drugs. And as you can see, there is an estimated 5.6 million individuals that will be affected in the United States by 2050 who have atrial fibrillation, and globally these estimates are as high as 10 to 15%. Especially in the older age ranges and the octogenarians, those that are 80 and older, you can see that atrial fibrillation is an age-dependent disease that increases with each decade. So on our next slide, we're going to review what is the major trials with the novel oral anticoagulants or NOACs. And over the past half century, pretty much the only drug that's been available has been warfarin. And now in the last few years, we've really had an explosion in the number of new drugs that are available in the market. And the drugs shown here, Dabigatran, apixaban, edoxaban, and rivaroxaban, shown with the major trials, RELY, Aristotle, Engage, and Rocket AF, the major trials respectively, have really given providers more options for anticoagulation for atrial fibrillation. And each one of these drugs represents a new FDA-approved therapy for stroke prevention. And so the endpoint that we're showing in this slide is really the reduction in stroke or systemic embolism compared to warfarin. And what you can see is that in the Dabigatran trial, RELY, the dose 150 milligrams twice a day, the apixaban trial, edoxaban and rivaroxaban, the pooled analysis shown here favors these drugs over warfarin in reducing stroke and systemic embolism with a large pooled number of patients, about 58,000 patients. However, you can see on this next trial, this meta-analysis of these trials, while these agents were useful in a favorable risk-benefit profile and reduced stroke and had lower rates of intracranial hemorrhage, and for example in the RELY trial, the incidence of intracranial hemorrhage was about 0.1%, compared to warfarin of about 0.4%. However, there was increased gastrointestinal bleeding in these trials, and it should be noted by providers. The other caveat in these NOAC trials was that most patients who had prior intracranial hemorrhage were excluded from these prospective trials. Lastly, the caveat is that there is no antidote for these drugs if major bleeding was encountered. However, the incidence of gastrointestinal bleeding or major bleeding and intracranial hemorrhage were monitored during these trials. And we'll touch on things that are developing to address that. So we get to our first audience response question here. So what is the hemostatic mechanism for rivaroxaban, edoxaban, and apixaban's anticoagulant effect? Is it A, factor 2 inhibition or thrombin inhibition, B, factor 5 inhibition, C, factor 10 inhibition, or D, none of the above? And now you can go ahead and key in your response. And so the answer is C, factor 10 inhibition. And in particular, these drugs inhibit factor 10A. And the key to remember this is that all these drugs have XA written in their name, as you can see there. And we'll go over this in detail, but it's a nice mnemonic to remember the drug's mechanism of action. So another audience response question: what is the hemostatic mechanism for warfarin's anticoagulation effect? Is it A, impaired hepatic synthesis of factors 2 and 7, B, impaired hepatic synthesis of factors 2, 7, and 9, C, impaired bone marrow synthesis of factors 2, 7, 9, and 10, D, impaired hepatic synthesis of factors 2, 7, 9, 10, and protein C and S? And so go ahead and key in your response. And the answer is B. So just remember, warfarin is in the family of vitamin K antagonists, or VKA for short, which impair the hepatic synthesis of hemostatic factors shown above 2, 7, 9, and 10, as well as protein C and S. So now we move on to the next slide, which shows this hemostatic pathway you probably recall from medical school, showing the intrinsic, extrinsic pathways as well as the common pathway. And it's worthy to go over this because of the different anticoagulant mechanisms. So vitamin K antagonists like warfarin impair factors 2, 7, 9, and 10. As you can see on the intrinsic pathway on your left, factor 9 comes down to factor 10, which goes down to factor 2, which is thrombin. And on the other right half of the pathway, the extrinsic pathway is activated when tissue factor is exposed. So this is like if you have a cut or on your finger, tissue is exposed. This activates factor 7, which goes to factor 7A, which then activates the common pathway you see in the middle there, factor 10 to 10A, 5A to 2, 2 to 2A, and to activate fibrin strands, which cause hemostatic plugging with red cells and so forth. Now, it's important to look at this hemostatic pathway in the sense that the factor 10A inhibitors, also known as Zabans, seen there and highlighted in red, and we mentioned these work on factor 10A, and I've highlighted the initials there, XA, in their name to help remember. These work on the common pathway, in the final common pathway, the hemostatic cascade. And you can see the last drug, Dabigatran, works on factor 2, which is near the bottom of the chain. And also, it's important to note that thrombin has a long half-life, and one reason why warfarin has such a long half-life, because you can see on the bottom left of the clotting factors, it has one of the longest half-lives of those clotting factors. And this is also why patients who take large amounts of oral warfarin can develop a hypercoagulable state, because it causes a drop in those that have a short half-life, such as factor 7, 4 to 6 hours, or protein C, and this can lead to those associated complications. Now, our next slide goes into some more pharmacologic considerations of these drugs, and we touched on the hemostatic factors affected, such as warfarin. You can see there factors 2, 7, 9, 10, protein C and S. Dabigatran, factor 2, which is thrombin, and apixaban, edoxaban, and rivaroxaban on 10A. Now you can see the half-lives there vary as well as the doses, and warfarin is the drug that is adjusted to the patient's blood test, the International Normalized Ratio, or INR, and the other drugs you can see resulted from those trials, and you can see those dose ranges there, as well as the frequency. Warfarin is typically taken daily, as well as edoxaban and rivaroxaban, whereas dabigatran and apixaban are taken twice a day. It's also important to note that these drugs have drug-drug interactions. Warfarin has numerous drug-drug interactions through its CYP2C9 mechanisms shown there. And the other ones also have important drug-drug interactions, namely with amiodarone, dromiperidone, verapamil, and other drugs. These are outside the scope of this talk, but it's worthy to perhaps look those up in patients to prevent drug-drug interactions that can lead to elevated or altered levels. So the next slide shows really one of the important basis of the talk, which is what causes spontaneous intracerebral hemorrhage during anticoagulation. In other words, why do patients have brain hemorrhage during anticoagulation? And the answer is that patients who have intracranial bleeding on anticoagulation are similar in terms of pathogenesis to those who have spontaneous brain hemorrhage, meaning those who do not have trauma and spontaneously develop a brain hemorrhage. The difference is that they're taking anticoagulation at the time. Studies have shown the pathologic changes occur in the small arteries of the brain and causes hardening of the arteries, what's called lipohyalinosis. And these blood vessels are typically the small ones that occur at branch points. And as shown in the diagram there, one of these deep basoganglia perforating arteries that leads to a basoganglia hemorrhage, as shown in the figure on the middle right. And also we know from more than 100 years ago, Charcot and Bouchard described these so-called microaneurysms that occur in the same branch point type locations, and these are thought to be the site where intracranial bleeding occurs, which in the setting of anticoagulation can be magnified. So a few more important points about this disease is that the incidence of intracranial bleeding on anticoagulation increases about 2 to 5 times when patients on anticoagulation, depending on the intensity of the anticoagulation. Second, other factors increase the risk, including advanced age, such as octogenarians, higher anticoagulation levels, such as an INR greater than 3.5, prior intracranial bleeding, ischemic stroke, or white matter disease, also known as leukoariosis. It also increases with uncontrolled hypertension, such as a systolic that is elevated higher than 160 or even higher, or when agents such as antiplatelets drugs such as aspirin or clopidogrel are added to anticoagulation. Further, patients who have microbleeds or cerebral microbleeds, CMB, seen on brain MRI, have a 8-time increased risk or odds ratio, as shown there, of increasing risk of intracerebral hemorrhage. And in terms of the overall types of intracranial hemorrhages, they're mostly intraparenchymal, which is also known as intracerebral, and there may or may not be intraventricular bleeding or blood within the spinal fluid cavities of the brain, followed by subdural hematoma being sort of the second most common type, and rarely spinal cord bleeding. So let's take warfarin intracranial hemorrhage for example, since it's the most well-known and studied type of anticoagulation hemorrhage, historically speaking, over the past half century. It is a deadly entity with about a 50% one-month mortality, and warfarin intracerebral hemorrhage tends to be larger than those cohorts who do not take anticoagulants. The appearance of the bleeding can be complex or even have a fluid level, which suggests the blood has not congealed within the hematoma compartment. And these patients can continue to bleed after 24 hours, which is unusual in non-anticoagulated intracerebral hemorrhage. And in most definitions, warfarin intracerebral hemorrhage is usually defined when patients have an INR greater than 1.5. If it's less than that, it's thought to be perhaps more of a spontaneous hemorrhage, less likely associated with the warfarin. And you know that the international normalized ratio is a surrogate for the percent and inhibition of those vitamin K-dependent cofactors. So on the next slide, what we see is the two types of intraparenchymal hemorrhage locations, generally speaking, and they tend to fall into either lobar intracerebral hemorrhage, shown there labeled A, because they happen in the lobes of the brain, and these should immediately raise a question that the patient may have cerebral amyloid angiopathy when there's a hemorrhage spontaneously on anticoagulation this far out distally in the brain. The second type are deep hemorrhages shown, B, C, D, and E labels, and these tend to be more hypertensive, quote-unquote, in origin due to the pathology we just discussed with lipohyalinosis and the historical discovery of Charcot-Bouchard hypertensive brain hemorrhages. Further, this next slide shows the appearance of cerebral microbleeds on gradient echo imaging. So the image on the far right, these little multiple black BBs or dots, are little microhemorrhages seen on MRI. And when this is seen, this should raise the question about cerebral amyloid angiopathy or lobar microbleeds, which can give rise to macrobleeds or intracerebral hemorrhage later. And these are seen in 15% of patients older than 70, sometimes are associated with warfarin use and also antiplatelet use. And when you see these microbleeds on MRI, typically when they're in the lobar location, you think of cerebral amyloid angiopathy, which is a fragile blood vessel condition that can lead to breakage of those small vessels and bleeding. Or if they're in the deep location, you think about hypertensive causes. So on this next slide, what you see is a gradient echo MRI in a patient who's had a macrohemorrhage there on the right MRI image. This is a basoganglia hemorrhage that extended up to the near the surface of the ventricle. And on the image on the left, what you see is the hemorrhage is in the basoganglia with scattered surrounding cerebral microbleeds labeled there CMB. And so this patient had terribly uncontrolled high blood pressure in the 180s to 200s for many years, and he developed a deep intracerebral hemorrhage. And on MRI, you can see the telltale clues of these microhemorrhages or cerebral microbleeds. So the next slide goes into an important sort of big picture view of the rates of intracerebral hemorrhage depending on various factors. And so in the general population, the rates of intracerebral hemorrhage are about, in a 70-year-old person, are about 0.15% per year, so fairly low. And when aspirin is added in the setting of atrial fibrillation, it goes up to 0.2%. And if you add cerebrovascular disease, such as white matter disease or Lacunes, for example, it can go up to 0.3%. When you add aspirin and clopidogrel with atrial fibrillation or with cerebrovascular disease, it increases to 0.3 to 0.4%. And the highlighted box here of interest, the patients who are anticoagulated with an INR of 2.5 who have atrial fibrillation and or cerebrovascular disease, these rates increase significantly to 0.4 up to 1% per year. And when you add aspirin to warfarin, this can go up to 0.5 to 1% per year. So these are important rules of thumb in terms of the rates, in terms of what we'll talk about later. So the next slide goes over a nice study by Fang, and the importance of this is on the upper left. What you see is the age dependency of the odds of having intracranial hemorrhage in the setting of anticoagulation, and the arrow shows that there's an upward curve after patients reach 80 years of age and older. And this makes sense because of the aging blood vessel phenomenon in the brain. They become more fragile, similar to your skin as you age gets more fragile and more prone to bleeding and bruising. And also on the bottom right, what we see is that the intensity of the anticoagulation has an effect on the odds of increasing the rates of ICH during anticoagulation. And the INR value is 3.5 and higher. You can see there's a steep portion of that curve that increases. So in many ways, age and the anticoagulation intensity can somewhat be a stress test for perhaps occult cerebral microhemorrhages in these patients. So our next slide goes over the what's called the BAT study, or the bleeding with antithrombotic therapy study. And which was a study of 4,009 patients who were on oral antithrombotic agents, and their blood pressures in the clinic were measured before the patient developed a symptomatic intracranial hemorrhage. And the importance of this study is that the increase in blood pressure during the antithrombotic medication was positively associated with the development of ICH, underscoring the importance of blood pressure control on the development of avoiding intracranial hemorrhage. And this was also, the effect of blood pressure was studied in the Progress trial as well, and subsequent stroke and intracranial hemorrhage risk factors. Now the next slide goes over 8 patients that we studied with warfarin intracerebral hemorrhage, and they just show the different CT scan phenotypes, if you will, of the different types of warfarin intracranial bleeding. So patient 1 is a large lobar hematoma. Patient 2 is again a right posterior occipital lobar hematoma, and this patient in fact had surgical evacuation and was found to have cerebral amyloid angiopathy on brain pathology. Patient 3, 4, 5, and 6 all had uncontrolled hypertension, and what you see is a predominant intracerebral or deep pattern of bleeding with some intraventricular extension, especially in patients 4 through 6. Patient 7, again, was lobar in location and raises the concern for amyloid angiopathy, and patient 8 is a patient with prior cerebrovascular disease. As you can see in the patient's left hemisphere, there's a dark area as well as a traumatic tricompartmental subdural hematoma. This patient had a fall, and this is a traumatic warfarin-related subdural. So now we'll move along to the next phase, which is the acute management of patients with anticoagulation-related ICH. And we'll start off with a question. This is question 3, our first case study. A 37-year-old female who was on warfarin for valvular atrial fibrillation who presented with acute right hemiplegia or weakness, and her INR was 4.4. She was super therapeutic. So the question is, what is the best next step in her care? Is it A, hold warfarin, admit to the hospital, B, hold warfarin, administer prothrombic complex concentrates or PCC and IV vitamin K, C, administer IV recombinant factor 7A and vitamin K, or D, none of the above? And you can go ahead and key in your response. And so the answer is B. The recent American Heart Association guidelines by Morgenstern suggest that stopping the warfarin and administering prothrombic complex concentrates and intravenous vitamin K in the setting of intracranial bleeding are the main recommendation. So this next slide is an overview of how to approach the patient who is on anticoagulation who develops stroke signs. So at the top, what you see is the patient may develop worrisome signs for intracranial hemorrhage or bleeding, and so the symptoms to look out for would be headache or focal neurologic deficit such as weakness or numbness, and the approach should be to start off with a non-contrast head CT. The reason being is that the non-contrast head CT has a high sensitivity for detecting intracranial blood, and so if that's discovered, the next step by this algorithm is to determine, does the patient have an operable lesion, or are they a candidate or not? And so on your left, for patients who do have an operable lesion or a problem, the question is, are they symptomatic or not? So if it's an asymptomatic CAT scan finding, they may not need surgical intervention. And also in the guidelines, it suggests such patients should be salvageable, meaning that they're not fixed and dilated in their pupils or moribund. And one indication would be symptomatic hydrocephalus. So if there's blood in the ventricles, that can be alleviated by placement of a ventriculostomy catheter to alleviate spinal fluid pressure is one indication. A cerebellar hematoma with mass effect, and then lastly a subdural hematoma with mass effect are potential surgical indications. So if a patient has such an intervention, an ICP monitor may or may not be placed, and you can see on the bottom left the question is if the ICP is controlled. If not, we would move to the bracket there of interventions medically. If the ICP is controlled, in the bottom left you can see the patient's typically monitored in the intensive care unit, or at least for clinical monitoring. Now going back to the top, if the patient doesn't have a surgically amenable process, then maximal medical therapy is suggested, and in the guidelines it suggests that an ICU admission, preferably with nurses who have neuro specialty training, are advised to help detect neurologic deficits as they arise. And as you can see at the top of our algorithm here, the 1A intervention is anticoagulation reversal. 1B is also a triage of their airway and breathing. And we'll touch on 1A, which is the anticoagulation reversal, next. So breathing, if the patient has a Glasgow Coma scale less than 8, then move down to item 5, which is potential intubation, mechanical ventilation. Item 2 relates to the blood pressure and cerebral perfusion pressure, or CPP control, based on the AHA guidelines. So if the patient has intracranial pressure that is not elevated, the target blood pressure is considered a modest reduction down to a target of about 160/90. If there is a suspect intracranial pressure elevation, the target blood pressure can be higher, up to 180, and the CPP, since an ICP monitor is presumably in place, the CPP goal in those patients is at least 60. Now, item number 4, osmotherapy, or drugs that increase the blood osmolality, can be given if the patient has clinical signs of herniation, such as a blown pupil, or if the intracranial pressure is greater than 20 millimeters of mercury. And these can include mannitol dosages between 0.25 grams up to 1.0 grams per kilogram as an IV push bolus, and these can be repeated at the frequency shown there. Or if the patient has a central line, you can do a 3% hypertonic saline infusion, or boluses of hypertonic saline, either in 2 types, 14.6% or 23.4%. And the goal plasma osmolality can be around 320 or less, and the serum sodium 155 or less. If patients continue to have raised intracranial pressure, further deepened sedation, mechanical ventilation, and or use of neuromuscular blockade can be used. And the last step, 6, there is hypothermia and or barbiturates. And then number 7 should be addressed if the patient's refractory to all of the above, perhaps rediscussing with the surgeon if there's any surgical intervention, such as an external ventricular drain for hydrocephalus, or craniotomy for intraparenchymal hematoma evacuation, or subdural hematoma evacuation as applicable. So the next slide is an overview over the pharmacologic intervention to how to reverse these agents and anticoagulation. So on your left, what you see is warfarin. And warfarin, the recommended dose is 10 milligrams of IV vitamin K, slowly infused over 20 to 30 minutes. And this is usually in conjunction with one of the middle brackets there, either prothrombin complex concentrates, either 3 or 4 factor, and that you can see the dose ranges in the studies to date have ranged from between 25 to 50 international units per kilogram, but the dosing is based on the INR. If PCCs are unavailable, a dose of FFP can be given. You can see the range. It's a weight-based dose as well, even higher doses if the INR is even higher. In places in which case PCC and FFP are not available, recombinant factor 7 has been reported in a wide range of dosages. All of these middle bracket strategies of hemostatic factor administration should target an INR of 1.5 or less in the setting of intracranial bleeding to prevent hematoma expansion. And then bottom bracket there is frequent coagulation assessments such as PT, INR, and activated PTT could be checked frequently. It depends on the hospital protocol. For example, ours is to check it every 6 to 8 hours for the first day to make sure that we're meeting our target INR and redose the reversal agent as needed. and then we check it for a few days to make sure that there's no rebound in the INR and further bleeding. So what about the middle column with Dabigatran? Well, both Dabigatran and the outer right quadrant column there, the Zaban agents such as apixaban and rivaroxaban do not have any known antidotes that have been studied in prospective randomized human trials or phase 3 trials. There are anecdotal, meaning case or class 4 or small series of patients who have been given various hemostatic factors, which I will describe. However, for Dabigatran, the package insert after the drug was approved and in the RELIDE trial suggested if major bleeding occurred to administer activated charcoal to limit any oral or enteral absorption of the drug if they had just taken that prior to the bleeding. Also, hemodialysis is recommended as it can remove up to 50% of the drug if the patient is going to emergent surgery or if the patient has a poor kidney function. If these measures are performed, an adjunct to that hemostatically can be the administration of prothrombic complex concentrates, either 3 or 4 factor. Again, the data is less clear on these drugs, or recombinant factor 7. And in the study or the article by LaRue, they suggest even DDAVP could be considered added to this. Again, these are not prospective trials, but individual either case reports or human trials in which they administered the drug with the PCC or other hemostatic agent, but not in patients with intracranial hemorrhage. And in the bottom, what you see is in terms of monitoring, the activated prothrombin time is a qualitative surrogate for the level of Dabigatran, but it's really a poor correlate of the actual therapeutic dosing or response. So you might see a patient who has Dabigatran have an elevated PTT, and that indicates that perhaps some of that drug is in their system, but it also might be normal. So the current coagulation tests we do for warfarin are inadequate. And there are some specialized tests shown there called thrombin time and heparin clotting time, but these are more quantitative, but they don't typically have a rapid turnaround time for emergent decision-making in patients with intracranial bleeding. So the last column there, the Zabans, again, there is no known antidote currently, but we'll talk about some recent studies going on. PCCs as well as FIBA, which is an activated PCC, have been suggested based on those references there. And for those places who do not have PCC or FIBA, again, recombinant factor 7 has been suggested as a universal hemostatic agent. And there are some that suggest that the anti-factor 10A level could be used to trend to measure the effect of those drugs as it wears off. And some suggest hematology consultation to help in the product administration, being the lack that there is no antidote. So on our next slide, I'm just going to briefly mention warfarin in detail and the different pros and cons of these different options. So vitamin K is the standard, and in symptomatic intracranial hemorrhage by the ACCP and AHA guidelines, 10 milligrams IV as a slow infusion is generally recommended in conjunction with one of those other options, 2, 3, or 4 shown below. The reversal time, however, takes about 6 hours to start to kick in, and it starts to replenish the vitamin K levels for your liver to produce those vitamin K factors. There is a low risk of anaphylaxis, 1 in 10,000 patients. It's likely rate-related, as well as the solvent that was present in the older forms of the phytanidone or vitamin K. K1 is the name. The second option, FFP, it takes considerable time to thaw, match, and infuse, and some studies show that it can take up to a full day by the time the INR is corrected by using FFP. Also, keep in mind that this can lead to significant volume overload, cardiac congestion, and transfusion-related associated lung injury or TRALI have been reported. rarely bloodborne infections are reported. The third option, recombinant factor 7, is fast. It's basically a bacterial-produced protein powder similar to insulin, so it's pure. It's not human-produced, and it's reconstituted in a vial and injected as a bolus, and it rapidly reduces the international normalized ratio, but it also has a short half-life and can cause a rebound in the INR unless vitamin K or another agent is given. And then the last option, PCC, we talked about, are smaller volume compared to FFP, easier on patients with cardiac low ejection fraction. Their cost is less typically than recombinant factor 7, but both recombinant factor 7 and PCC, because they're procoagulant drugs, can be associated with some thromboembolic risk. And this next slide shows you just the variability in the PCC factor content. So whatever hospital you're at, it should behoove you to know what kind of agent you have as well as the factor content. And I would suggest coming up with some kind of protocol and or dosing regimen. And much of this is sometimes on the package insert or studies there. And for example, Bebulin and Variplex shown at the top are common ones in the United States, and as well as Profilnine in Europe. I think Octaplex is more common. So on our next slide, just goes over a recent study, a 4-factor phase 3B trial that looked at warfarin major bleeding, and here's an example of such a nomogram that you could use at your hospital. So when the INR was 2 to 4 range or so, they gave 25 international units per kilogram of body weight, and to reverse the warfarin in those patients. You can see the dose range on INR and the other ranges, 4 to 6, greater than 6. Next slide shows why not recombinant factor 7. Well, part of the enthusiasm for recombinant factor 7 dropped after the phase 3 trial looking at this drug in patients not on anticoagulation, and the drug showed in a phase 2 trial reduced hematoma growth, but did not improve survival or functional outcome in the phase 3 trial. And as you can see, as these modified Rankin bars show up, the dosage in the phase 2 trial, 20 or 80 micrograms, there was really no difference in good outcomes when you look at modified Rankin 0 and 1, for example, versus those who had a poor outcome, grades 5 and or particularly 6, which is death. So our next slide is a question, number 4, which is case study number 2. This is a 71-year-old female who was on rivaroxaban for atrial fibrillation, hypertension, who came in with headache, nausea, emesis, and a Glasgow Coma scale of 14. So she was somewhat drowsy, but she would open her eyes to voice. She would follow commands, and she was oriented. She did have significant neurologic deficits, however. She had right hemiparesis, left-sided ataxia, as well as dysarthria, and her NIH stroke scale was 16. As you can see, her PTT was slightly elevated, and her blood pressure was really sky high, 220 over 110. So the question is this patient a surgical candidate? A is yes, potentially after intervention, hemostatic intervention, or B, no, the patient's not a surgical candidate based on what we just reviewed. And you can enter your response. So the answer is yes, potentially after hemostatic intervention. This would meet the cerebellar hematoma, as we discussed in the guidelines, as a potentially surgical candidate. So the next slide just goes over follow-up in this patient. At our hospital, we did not have 4-factor PCC at the time, and she received a 3-factor PCC called Bebulin, and she had her blood pressure tightly controlled using an cardipine drip. She was taken to the operating room after she was typed and screened. She was woken up and extubated, and she's been kept off of rivaroxaban, and her NIH has actually, stroke scale has returned to normal 2 months out. But you can see on this next image her gradient echo MRI, showing there's still microscopic bleeding in that cavity despite the resection. And the next image there shows the higher cuts of her brain above the in the anterior compartment or above the tentorium, showing she does not have findings suggestive of amyloid angiopathy. And so her cause of her bleeding was uncontrolled hypertension and the deep location, as we reviewed earlier. So just briefly about other antithrombotic management. So patients may be taking aspirin or clopidogrel at the time they bleed, and they may require a platelet transfusion, as you can see based on the guidelines. And there's one study by NADEC looking at DDAVP administration to improve platelet dysfunction in those patients. In patients who happen to be treated with TPA, you can see the suggested regimen is platelets and cryoprecipitate to reverse the hemostatic defect. And then lastly, patients who have heparin-related intracranial bleeding, the recommendation is protamine, 1 milligram per 100 units of heparin given. So on to the management of the patient's blood pressure. This is from the American Heart Association guidelines. And so you can see the initial management if the patient's systolic is greater than 200, then consider aggressive reduction with a continuous IV infusion and frequent blood pressure monitoring every 5 minutes. Bracket number 2 shows if the patient's systolic is greater than 180 and there's concern about elevated intracranial pressure, to consider intermittent or continuous IV medications while maintaining a cerebral perfusion pressure greater than 60. And then the third recommendation, if the systolic is greater than 180, but there's not a concern for elevated intracranial pressure, they recommend a target modest reduction of blood pressure to around 160 over 90 using intermittent or continuous IV medications. So our next slide goes over a recent prospective randomized trial in which the guidelines by Morgenstein did not have at the time of their review, which was called the Interact-2 trial, in which they randomized patients with intracerebral hemorrhage to either intensive blood pressure lowering less than 140 systolic or a guideline range of less than 180. And the bottom line of this study is that there were trends toward a better intensive treatment, as you can see in all these other metrics such as NIH stroke count, hematoma volume. But on the far right, you can see that the p-value for homogeneity was not different, and the authors concluded that there was a non-significant reduction in the rate of the primary outcome, which was death or severe disability. When they looked at the data more extensively, they suggested that there may have been improvement in the patient's functional outcome as measured by modified Rankin. However, there's another trial we'll mention at the end that is challenging the same precision in blood pressure that we'll talk about called ATACH-2. So the last topic we'll review before we finish is when and if to restart anticoagulation after intracerebral hemorrhage. And so on this slide, this tries to show this risk-benefit ratio is akin to the sword of Damocles, which is shown in the figure there, which is the proverbial sword that hangs over someone's head. And this is the risk in someone who's already had a potentially life-threatening intracranial bleeding who goes back on the medication. And there's patients who are on the medication alone, that's certainly the most feared complication. But in patients who go back on it, this can be a very complex and even controversial decision with their healthcare team. And it's often very individualized to the patient, such as some of the factors we went over, their blood pressure control, do they have amyloid angiopathy, uncontrolled hypertension, and so forth. There's also some that believe, in one study by Ekman in a Markov analysis, that patients with lobar hematomas may have a longer or higher risk of restarting anticoagulation than those with deep intracerebral hemorrhage risk based on that reference. And also there's some controversy whether patients with cerebral amyloid angiopathy should be excluded, although that diagnosis is difficult in life unless there's brain tissue based on the Boston criteria. Definite diagnosis of CAA requires brain tissue, such as a brain biopsy or autopsy. Suspect and probable are the next other categories based on imaging and or history, such as dementia and so forth. The third point there is that blood pressure cannot be overstated, as some of the data we reviewed. And then the last point is that the risk-benefit ratio can be calculated by two useful formulas. One is called HAS-BLED, which if you type in Google or some other app, for example, they have these calculators. And HAS-BLED is a score we'll review which calculates the risk of major bleeding in people on anticoagulation, and the CHADS-2 VASC scale is the opposite, is the risk of ischemic stroke during in patients with atrial fibrillation. So this is a good sort of risk-benefit ratio of the risk of bleeding versus the risk of ischemic stroke. And this next slide shows this narrow window in the vertical black bar from data compiled from HILEC. And you see that there's a narrow therapeutic index of warfarin, and if you go out to the far right, this red dashed line shows that the risk of intracranial hemorrhage increases as the INR goes up, and we talked about that. However, if you go to the left and your INR is subtherapeutic, you're at risk for ischemic stroke. So this is again that problem with warfarin and the narrow index. So our next slide just shows you what the CHADS-2 VASC score is, and on your left, this is the components for the acronym there. You can see C for congestive heart failure, H hypertension, A age, D diabetes, stroke, vascular disease, age, and these add up to between 0 to 9 points, and you can see the stroke rate per year from 0 to 15% per year. Now this can be compared on the next slide to the HAS-BLED score, which is the risk of major bleeding. And so on the far left, you see the points that are added for each component, such as hypertension, abnormal renal and or liver function, stroke, bleeding, labile, INR, elderly patients that are older than 65, and drugs or alcohol excess. So if patients are taking nonsteroidal anti-inflammatory drugs or drink 8 more drinks of alcohol or more per week. And this is important because a HAS-BLED score of 3 or greater is considered high risk, or about 5.8% risk of major bleeding, and those patients, it's advised to be cautious with the use of warfarin. So these two scales can help weigh that risk-benefit ratio with your patients, although clinical judgment and other factors should be taken into account based on what was talked about. So our next slide is just sort of a summary of the data about restarting anticoagulation after intracerebral hemorrhage. And one review by Aguilar showed that when they pooled the available studies of patients that had intracranial hemorrhage on warfarin, in about 132 patients, some were very high risk with prosthetic heart valves. They were able to restart the warfarin after about 14 days or so, and some were bridged with heparin to warfarin because they were considered such high risk. There was a low rate of bleeding, although this was a pooling of mostly retrospective case series or case reports, and the embolic events were fairly low, about 3% by a month. And a more recent study of about 2,869 patients suggested that the optimal time appeared to be between 10 to 30 weeks after warfarin intracranial hemorrhage. And this would appear to make more physiologic sense, since patients their brain may take time to heal up and the blood-brain barrier to seal up, and so that they will not have bleeding, and hopefully the blood pressure or other factors have been elucidated and controlled. Another point there is that some patients or some consider switching to the newer agents instead of vitamin K antagonists like warfarin, especially if the patient has very labile INR, such as that young patient I mentioned. She likely has some pharmacogenomic explanation why her INR goes from subtherapeutic to very high and dose-adjusted warfarin. So some would suggest, based on the NOAC trials, that the incidence of ICH is so low, those might be better drugs, although that's vetted against the concern that these drugs have no antidote. So that's a highly individualized decision. And then some patients, even higher risk of recurrent intracranial bleeding, aspirin may be considered because it has approximately a 21% relative risk reduction for atrial fibrillation, so it's maybe better than nothing for some patients, and certainly is less scary than putting someone back on warfarin or other anticoagulant. And then it should be mentioned last that not all patients who have intracranial hemorrhage, or if they have a potentially injurious brain injury from a warfarin or NOAC-related brain hemorrhage, it may not be safe to restart those patients on warfarin or a NOAC drug. And the particular patient in mind is those with elderly age that have cerebral amyloid angiopathy by either suspect by neuroimaging or history of coexistent dementia, who have sometimes recurrent intracranial bleeding without any antithrombotic, and so adding that to control their adding an anticoagulant to control their atrial fibrillation may be a treacherous endeavor. And lastly, I would encourage medical providers to document your risk-benefit discussion with the patient or their caregiver, and also provide them some information so they can seek attention if the decision is to go and put them back on anticoagulation, so they can get prompt attention. So our last question on the next slide is, which of the following drugs is FDA approved for both valvular and non-valvular atrial fibrillation for stroke prevention? Is it A, apixaban, B, warfarin, C, rivaroxaban, D, dabigatran, or E, edoxaban? And go ahead and key your response. So the answer is B. Only warfarin is approved for valvular and non-valvular atrial fibrillation. And then one of the cases that we presented, the 37-year-old young female, she had mitral valve disease that required a valvotomy through a percutaneous approach. So she had valvular disease and was only a candidate to go back on warfarin. She was not a candidate to try a NOAC drug. So our last topic is just to go over some future research, and this slide shows the Antidote clinical trials underway to hopefully address this vexing dilemma of not having an antidote for these newer NOAC drugs. So the first drug, idarusuzumab, if I said that correctly, is the reversal of Dabigatran anticoagulant effect, and you can see the NCT number found at the clinicaltrials.gov website, and this is believed to be an antidote for Dabigatran, similar to a Fab fragment like digoxin or other Fab antibodies. And Dexanet is another antidote for factor Xa inhibitors, as is Repazine, PER-977 for factor Xa inhibitors, and it's also presumably can work for low molecular heparinoids and fondaparinux. So our last slide is ongoing trials that may help with some components of anticoagulation intracerebral hemorrhage. Namely, the CLEAR-3 trial is a study that is a randomized trial with about 5 patients left, looking at the bleeding inside the ventricle, in which TPA is injected through a ventricular catheter to dissolve that intraventricular blood out. But there is some eligibility in that trial that they can have their warfarin reversed, and they can be included in the study if they meet all their inclusion-exclusion criteria. We also made reference to the ATTACH-2 trial, which is a phase 3 trial, trying to answer that question about precision of where that blood pressure needs to be, less than 180 or less than 140 systolic. There are some that believe that a higher systolic blood pressure leads to more pressure and pipe breakage and more bleeding, and there are others that believe that by controlling the blood pressure more aggressively, there's less bleeding going on intracranially, but some are concerned that the brain might need a higher driving pressure. And then lastly, the left atrial appendage occluder devices, such as Watchman device, and there are many others if you search the clinicaltrials.gov website that are investigating ways to occlude the appendage of the left atrium to prevent embolism to the brain. And you can imagine if there are patients who cannot be anticoagulated, this would provide a useful therapeutic intervention for patients such as those with cerebral amyloid angiopathy. So in conclusion, hopefully you've learned during this short time that the intracranial hemorrhage during anticoagulation is a life-threatening emergency that requires prompt attention and organized approach for anticoagulation, reversal, and blood pressure control. This disease will likely increase due to the aging population and the prevalence of atrial fibrillation, despite the ICH rates of NOACs being about 0.1% and Warfarin about 0.4%. And it's important for providers to keep in mind to avoid dual antiplatelet regimens with anticoagulants because that can increase the intracranial hemorrhage rate significantly. Also, keep in mind that these antidotes are being studied in trials, and also there are these additional trials attached to for the blood pressure parameter between 140 and 180, and the CLEAR trial with regards to treatment of the intraventricular hemorrhage component. And last but not least, keep in mind that long-term outpatient blood pressure control is one of the most profoundly important interventions to reduce CNS bleeding. And with that, I'll stop, and thank you for your attention.
Thank you, Dr. Freeman, for this thorough talk on this very important topic. The percentage of patients on anticoagulation is growing dramatically, so we are going to see more of these patients in the future. Again, thank you for this important topic, and please stay tuned to this area as we move forward.